that electronic health records are the cornerstone of the President's healthcare initiative, that number is expected to rapidly increase. Massachusetts is part of a nationwide effort to educate healthcare consumers about privacy and security of their electronic health information. Tonight we'll see a brief video addressing these issues. It's called Balancing the Risks and Benefits, Sharing Sensitive Health Information. The video was developed to help people understand some of the issues around electronic sharing of personal medical information. So in the video, experts in the healthcare community discuss the benefits and risks of sharing electronic information. It presents the rules of information transfer, patients' rights, consumer concerns, and suggested questions to ask healthcare providers. Special attention is paid to behavioral health and mental health information, which have additional rules for sharing. Now, in the film, you will see participants such as David Szabo, a health law attorney for Nutter, McClellan, and Fish, and he's also a Winchester resident, and he's here tonight. John Halamaka, who is an emergency room physician and a chief information officer for the care group in Harvard Medical School. Lisa Fennicle is an e-health consumer advocate, Healthcare for All. Stephen Locke is a Massachusetts psychiatrist. Mark Hauser, is a Mass psychiatrist and officer of the Mass Psychiatric Association. And Geraldine Heinold, who's sitting with us tonight. And I'll give a brief introduction to her in a little more depth in 1 minute. She's also a Winchester resident. Now, following the video, we'll have a brief question and answer period so that you can ask our panel some questions. Our panelists this evening are David Szabo, as I just mentioned, Geraldine Heinold, and also sitting up there is Diane Stone. Geraldine Heinold has worked for healthcare for more than 25 years in positions such as clinical lab manager and smoking cessation researcher. For the past few years, she has focused on the privacy and security of health information sharing and is currently the director of the federally funded Multi-State Consumer Education and Engagement Collaborative. She is very interested in getting patients and their families the information they need when they need it. She is a Winchester resident, and although not considered a native because she's only been here for 35 years, she served on the Winchester School Committee for 6 years. So that's a little bit about Geraldine. So this panel is here for you at the end of the video. And I'm going to hand it over to Geraldine now, who's going to continue on with some more information for you.
Diane Stone has many years of healthcare management experience that address the industry's changing business processes and practices. Her expertise is project management and organizational implementation of health information exchange, with a focus on privacy and consent requirements. Since 2006, Ms. Stone has served as a project director for the Mass Health Information Security and Privacy Collaboration, fondly known as HISPIC. And most recently, she's been co-chair of the Multi-State Disclosure and Patient Consent Collaborative. So tonight, we're going to be talking about what is HISPIC, what is this privacy and security collaboration, why is it important? And then we're going to focus on the Massachusetts projects of the Consumer Education and Engagement Collaborative. And then we're going to see the video. It's about 13 minutes, Balancing Risks and Benefits, Sharing Sensitive Health Information. And then we're going to have Q&A and discussion. The goal of the Health Information Security and Privacy Collaboration was to advance clinical information sharing so that when you go to a doctor, actually when you have several doctors, it allows you to have an integrated healthcare record so that your primary care doc can know about the information that your specialists have gotten. And with that goal, I'm going to turn it over to Diane Stone, who's going to do a little history of these projects, and then we'll come back to what Massachusetts has focused on.
Good evening. We are pleased to have this opportunity to go over some of the activities that at the federal level, the Department of Health and Human Services has been funding since 2006. The topic, as Geraldine just indicated, does address the privacy and security of your personal health information and this nationwide goal to have it available electronically when it is needed, most importantly for your treatment, to have it available easily, quickly, which is not the case today if you are at any kind of healthcare organization or provider office that does not have an electronic medical record. If you are still in the paper-based system, the information may not be, more times than not, getting where it has to be so that there's some accuracy and the best level and quality of care can be available to you. So the federal government and the state governments have been funding early projects to figure out how can we have your personal health information available when it is needed to treat you. The Health Information Security and Privacy Collaborative, HISPIC, formed in 2006 with projects through 2009, has been a nationwide initiative to understand the barriers, the challenges, and hopefully the solutions to what we call HIE, Health Information Exchange. You're probably all thinking that the technology is the challenge. It isn't. The focus really is your understanding, the consumer, the patient, the people's understanding about what this means. Because in Massachusetts especially, and in most other states across the country, your consent and your understanding about what it means to share information electronically is what the challenge in front of us. That's why we're filming this tonight, to make this information available to the widest audience. We've had a lot of other distribution and dissemination projects to get this information that you're going to see tonight available to the most amount of people, because someday you're going to get asked, is it okay if we share parts of your medical information when it is needed by someone else across town, across state, across a region? And you need to know that you probably have to say, yes, it's okay. And we want you comfortable with that answer. So the challenges are, there's a very complex hierarchy of privacy laws, policies, and practices in this state and in most states, certainly in the Northeast and across the country. It's complex. These laws were written long before electronic health information exchange, yet they are being applied to electronic health information exchange. So without getting any more complex myself, tonight's focused on the need to involve you as a consumer to build trust and to understand what is going on.
Thanks. So the collaborative that resulted in this video tonight was called the Multi-State Consumer Education Engagement Collaborative. And we had 8 states participating in it, and the states were very diverse in terms of their health care, how they produce it, what the requirements are in technology for it. And so we had states as diverse as Kansas, Oregon, the state of Washington, West Virginia, Massachusetts, New York. And so it became very challenging to figure out what kinds of projects we could have that would be useful for all of those states, because we're really at different places in our evolution, so to speak. Massachusetts is considered to be at the forefront of the technology that allows the transfer of information. And states like Georgia were still trying to figure out who they needed to talk to, who their stakeholders were. So it was quite a challenge to figure out how to develop projects that were useful for everybody. What we ended up deciding to do was to have each state come up with their own set of projects to move themselves along in their evolution, as well as a set of common projects that we were all felt were of interest to us. In Massachusetts, we thought that one of the areas that really needed work was in the area of behavioral health, mental health, sensitive information. That includes things like mental health, if you're on any medication for depression or other mental health conditions, that would fit into that category. Substance abuse, HIV, AIDS, And those rules in Massachusetts are quite extensive. Sometimes they overlap, sometimes they may even conflict. So we decided that consumers, patients, their families really needed to understand what those rules are and requirements are and what their rights were as patients who may have both physical and mental health challenges. So we came up with 5 projects that really address different learning styles in people. We know that people don't learn in the same way, and we wanted to really get the information out. So, for example, we developed a self-directed tutorial that is available online, a set of frequently asked questions that people could look up. We also had a legal inventory, and this Dave Szabo was instrumental in the development. It into something that was readable and understandable at the 8th grade level. In addition, we did an analysis of personal health records and tried to figure out what the needs of people are. Should they have a personal health record? What kinds of things did they need to look out for if they were thinking of buying one and putting their information into one? And this is a project that Diane led. And then we came out with a consumer guide so that if you're interested in personal health records and personal health information, you can look at this guide. They're all available online, and they're indicated later in this slide deck. You can see where to look them up. And finally, we developed a video on risks and benefits so that we could start looking at what the requirements are when you have sensitive information and really have some evaluation of whether it's right for you to share that information. So the themes for today's video are really how to consider and weigh the risks and benefits of sharing information, and also about trusting your provider and making sure you know the right questions to ask. Jennifer, so on the last page is where you can go for more information. And with that, I'm going to ask Jennifer to start the video.
As an emergency physician, mostly I'm flying blind. You come into the emergency department and I have to give you the right treatment, the right medications, the right safe care without necessarily knowing much about you. It's critical that you share information with your emergency physician, even sensitive information like mental health, HIV, or substance abuse history, because otherwise I'm likely to give you a medication that could cause harm or even death. It's very common that I see children coming in with their elderly parents, and I ask, well, what medications are your mother and father taking? And what I get is a bag with 14 pill bottles, and they say, yes, they're taking the red one and the blue one.
Fortunately, this situation is changing as more and more healthcare providers turn to electronic health records, which can be accessed quickly and easily to get accurate information. The benefits of electronic records extend far beyond the emergency room.
I can access everything from vital signs, progress notes, medication records. I can look at a record of previous surgeries and anesthetics. I can look at laboratory tests, and in fact I can graph them so I can see them over time. And I can look at films. It's organized in a way that I can access them quickly because they're under note titles and I can search for them more efficiently.
The average patient above the age of 70 has 10 doctors that they see. And that means they see a primary caregiver and a specialist and an ER doctor and a hospitalist. Oh, and they have a lab done by Quest. Oh, and they have a Shields MRI center. Their record is fractured.
Dr. Redfern, nice to meet you.
A lot of people change doctors all the time. You change health insurance all the time. There's no one place you can go to get your medical record.
An electronic medical record has the ability to bridge these gaps, improving both the quality and efficiency of healthcare.
When I go to a doctor for the third time, for the fourth time, for the fifth time, I don't want to be asked to fill out the same piece of information over and over and over again. I mean, there's always a chance that I'm going to get it wrong the fourth or fifth time.
And the pneumonia shot, do you know how long ago that was?
Maybe 3 years.
Okay. We'll get
The benefits of electronic health records are easy to appreciate. But what are the implications for the privacy of your sensitive information?
The easy access to the health information has a flip side too. The good side is you have ready access to it, and the bad side is other people might have ready access to it that you don't really want to see your record.
You might not want your dermatologist to know about your abortion. You might not want your primary care physician to know about your psychiatric issues.
And when personal health information is used for so-called secondary purposes, life insurance, the courts, media, law enforcement, sales, and research, a patient's need for control is even more important.
All patients are concerned about their health information, and it varies from person to person what they consider sensitive and private. It's inevitable that we will proceed with the development of modern computerized healthcare and the electronic medical records that go with it. The concerns that we have about the rights of the individual to privacy and to control their medical information and what's in there and who it goes to, that is of vital importance.
There's so many players in the healthcare market in the United States. It's just very complicated. And everybody who is paying for your health care or who is giving you health care treatment, they have a right to see your record. And they do.
Many laws exist to protect the privacy of your medical records, but understanding all the ins and outs of these laws is a daunting task. A good place to begin is the Federal Privacy Rule of the Health Insurance Portability and Accountability Act, better known as HIPAA.
When you go into a doctor's office or into a hospital or any other healthcare situation, the healthcare provider is required to provide a notice of privacy practices. So they're required to inform patients how the health information about that patient may be used or disclosed. The healthcare provider can use it for treatment purposes, so they can use it to treat you, to talk to a provider that they want to refer you to talk to another colleague, to consult about your case and that sort of thing. They can also use information in order to get paid for the service they provide, so they can submit information to your insurance company. And then the third category is healthcare operations, and that's some general office activities that a healthcare provider or a doctor would need to engage in, like sending out an appointment reminder or scheduling a procedure at a hospital or a clinic for you. It would also include things like disease management programs in order to help manage a patient with a chronic condition. The HIPAA privacy and security rules really provide a federal floor. The goal was to establish a baseline of protections nationwide. But there are a lot of state laws that provide additional protections.
Massachusetts laws are stricter than the laws of almost every other state when it comes to protecting sensitive health information.
Nearly 200 state laws govern the use of health information in Massachusetts. Some categories which receive extra protection include HIV and AIDS, mental health, genetic testing, substance abuse, and sexual abuse. The transmission of this information generally requires a patient's consent each time it is transferred.
For each category of sensitive information, the rules are slightly different.
For example, Federal Law 42 CFR Part 2 requires federally funded substance abuse clinics to obtain written consent before disclosing patient records. Many of these laws were passed to encourage people to seek testing and treatment without fear of exposure or discrimination.
One point that it's important for people to know is that the detailed personal notes that a therapist or a psychiatrist or any other mental health clinician writes in the record about the content of what you say is considered not shareable as part of the general medical record.
While psychotherapy notes have strict privacy safeguards, information about mental health diagnoses and medications can be shared if the patient gives consent, or if the information originates from a provider who is not a mental health provider.
So if a patient visits a primary care physician and talks with the physician about anti-anxiety medication, that information is not protected in the same way as that same bit of information if it is given to a psychiatrist. It's not the information so much that's protected, it's where the information is given. Mental health providers have that extra layer of protection on their records that other providers do not have necessarily.
For some, keeping their mental health prescriptions private is important.
Information on a prescription history is very informative. It might not have treatment information at all, but just what you've taken tells a lot about what you've had wrong with you.
On the other hand, prescription information is precisely the type of knowledge that other doctors need to know about in order to provide safe care.
You as a patient, of course, can decide what you want to share and not share with a clinician. Here's the challenge. Suppose that you come to the emergency department and you hide a mental health history. Mental health medications are the worst medications for drug-drug interactions. It's really likely that somebody's going to give you a treatment that could harm you.
Just as Massachusetts laws spell out how sensitive information can be shared between providers, there are specific laws detailing how sensitive health information flows to insurance companies.
Health insurance companies collect a lot of information from claims. When providers submit requests for payment, they have to say what's the diagnosis and what service was performed. They might know whether a patient has a mental health diagnosis, or they might know if a patient has had an AIDS test. They might not know the result, but they'll probably know whether or not the test has been administered. So in this state, in Massachusetts, they're specifically limited in what they can do with that information, and there are very detailed rules that tell them how they have to protect and control that information.
These detailed rules provide reassurance. But what protects us from those who don't follow the rules?
So often patients ask me, are my electronic records perfectly secure? And the answer I tell them is, they are as secure as technology can make them secure. But any technology with enough effort can be cracked. I am attacked on the Harvard Medical School and care group networks every 7 seconds, 24 hours a day, 7 days a week. Now, where do those attacks come from? Half come from Eastern Europe, and the other half from Eastern Cambridge, where MIT is located. I employ 4 people and spend $1 million a year protecting the security of electronic health records. So I will tell you, in the 10 years that I have been protecting health records, we have not had a breach of an electronic health record. But it is a constant Cold War.
Converting paper records to electronic format can be both helpful in terms of privacy issues. It actually can be more secure, and it can be less secure, all at the same time. A push of a button on computer records can transmit them to thousands of people, but one of the things with electronic records is you do have an audit trail of who's looking at your records. So you don't have that with paper records at all.
When thinking about privacy and security, I think it's about balance. Balancing the risks and benefits, and trust. Trusting those people who are taking care of you.
We're trying to make a complete loop, and then we'll probably do...
If your healthcare falls into specific protected categories, you have choices to make about when to consent to sharing your information.
As a psychiatrist, I still feel that the benefits of sharing personal health information in the medical record far outweigh the risks. Not only do I need to understand the patient's medical disorders and how they might interrelate, but it's important that I communicate back to that primary care doctor the medications that I'm treating the patient with, the potential for interactions, and that requires the ability to share information.
Information is really what makes the healthcare system go. The doctor knowing about your condition, the dietitian knowing whether you have a food allergy before they bring the tray up to the bedside, the pharmacist finding out what other medicines you're taking before they fill a prescription for a particular drug. All of those things require the use and disclosure of information.
Did you have a good time in Hawaii?
Actually, doctor, I didn't.
That's what I wanted to talk to you about.
Shoot, what happened?
Our ability to provide health care depends on the patient being forthcoming about all of their concerns, their symptoms, and a proper history. If they don't trust us and our discretion about the use of the electronic medical record, they may withhold information, and that could have dire consequences for their medical care.
The best way that people can participate is by having lots of conversations, and whether it's with their friends or their physicians, they need to know what their rights are and what questions they should ask and where they can go to find out more information.
We encourage you to begin your investigation by visiting the following websites:
Does anyone have any questions or things they would like to see explained more? Yeah.
You needed to have your records brought up to the state, and you asked the doctor, and he said, have them call me when you get there. And when the doctor did do that, they never got the records sent. So I'm wondering, will that take care of this problem when you move to another state? Would they be able to not have to call the doctor, just get the records themselves?
Okay, good question. Diane, you want to take that one?
That's what we call interoperability. Yes, that is the long-term, well, short, medium, and long-term objective of this goal. First, you have your medical information in an electronic health record, and then what actually happens, you don't need the whole record. There are a series of important kind of medical clinical points, maybe 20, maybe 25, I'm not quite sure what a clinical care record defines, but that's standard for what are critical pieces of information about you. And if you're in another state by choice of residence or vacation or anything like that, once this system is interoperable, a physician or other clinician in one provider office through a series of technology interfaces will be able to, with your consent, either request electronically and pull it from the other provider in the other location, not related. It's not in the same organization. That's why you have to have consent for it to be interoperable. It's either pulled from another database or it's pushed, depending on how those institutions set it up. But that's what it means. Yes, they can get a hold of it without being mailed, maybe, being faxed, maybe. It will be there, the pieces they need about medication, typically allergies, recent hospitalizations, things along that line, recent lab results. That's the whole beauty of it, yes.
And one of the key challenges now is that many physicians do not have electronic health records. Massachusetts is actually #1 in the country, for example, for e-prescribing, and they also have a much higher rate of electronic health information in their offices than the rest of the country. So in some ways it depends what state you came from or what state you're moving towards and whether your physician had an electronic health system. If they do, then they can typically produce something called, and Diane was talking about this, it's called a continuity of care record, and it has the key elements that your doctor would want to know. You know, they don't need the whole chart. They just need to know what's happened recently. Did you want to?
Sure. I guess I'd add to that is I think that the technology exists to do what you talked about,
Most doctors' offices don't have it. A lot of hospitals don't have it yet, so it's going to come. And I think the president has made it a big priority in terms of funding that kind of development. And in fact, Medicare is going to pay bonuses to doctors who implement electronic records and do it in such a way that they can share information and report quality measures and that sort of thing. So and the state has made it actually a goal to have a record sharing network by 2015. So, you know, I think the answer today is it could happen, and then probably within 5 years, the landscape is going to look a lot different than it looks today.
Other questions? Yes. Hang on 1 second.
Yeah, I find this all actually somewhat daunting, and I'm someone who's spent a lot of years in the information technology industry, and I'm also a lawyer by training and practice law for some years, and I can just see all sorts of issues and risks involved here. I mean, that gentleman who so blithely said that in 10 years there's never been a breach, I'd qualify it and say a breach of which he was aware. That's not to say there's never been a breach, because there could have been a breach that was done so well that no one was aware that the data was breached. So I find that somewhat facile, to make that comment, to try to instill confidence, in the general public. And, for all those of us who have, credit cards, I don't know how many times my credit card data has been breached in the last year, at least 3 times. And I don't know what sort of protections are going to be, applied, to the sharing of health data. I mean, this opens up an enormous can of worms in terms of the risks involved, in terms of, number one, correct information getting out, and the possibility of incorrect information about your health being leaked as well. I mean, I don't, I'll be honest with you. I just find this, given my own personal background and my understanding of the industry, I see some enormous risks here. I see the benefits as well, but I really can't, underestimate some of the issues, in terms of properly securing data. And that it may be well that institution, Caremark, whatever it was, may never have had a breach, but they might share information with another institution, may not be anywhere nearly as diligent. And it's only the information is secure as only as as the weakest link in the system. And it's all well and good that one hospital or one care organization may be absolutely wonderful in terms of protecting data, but once it gets to a less secure location, then the cat could be out of the bag. So there's no answers to any of this. I just raise these concerns. One question I had is what opportunity does a consumer have to correct information? So for instance, there's trying to correct information with your credit report is is a daunting task. I don't know, so what happens if, you had a negative HIV test and somehow someone miscodes and it's positive, and that gets out there? I mean, what safeguards are in there to help the consumer?
No, I'm sorry. It's just you can't. If we've been told if we don't use the microphone, it won't be picked up by the tape. So we have to bear with us while we walk around and do this kind of awkward process here. Fortunately, there's a better answer than exists for your credit report in healthcare, because federal law guarantees your right to review your medical record, and in fact sets time frames when your doctor or your hospital has to produce for you a copy, except under extremely limited circumstances, which are very, very narrow. So for 99% of all cases, you're going to get your record. It also gives you the right to say something is wrong and to require them to respond to that within a set time frame. I can't remember what it is, but they have to get back to you. And if they tell you, well, we think it's right, and you still say it's wrong, you have the right to insert what they call like an appendant, and not to change anything because it's a legal document, so you can't use whiteout on it. But you can actually put your own response to it and put it in there, which is very rare, but the federal law gives you that right to add to the record, and they have to make it part of what they call the designated record set. As to, security, I think anybody who tells you, oh, it's completely secure, well, that's probably humanly impossible. Errors have occurred. There are documented cases of errors occurring with paper records being faxed to the wrong place, and like the case of the traveling patient today, it'll be sent in the mail or something will be faxed. errors can and have occurred with those kinds of things. And I think generally, you know, there are you know, legal and technical standards that the industry is expected to follow. Anybody who says, well, I guarantee it'll always be perfect, is probably just being overly optimistic or trying to sell you a bill of goods. I do know Dr. Halamka, who appeared in the video, and he has invested a lot of time and effort in protecting those systems, and is nationally recognized as a chief information officer. But I think even he said, if somebody really wanted to attack my hospital and invest a lot of money in doing it, you know, but there are funny trade-offs. Geraldine mentioned we're the #1 state at doing electronic prescribing, which is generally recognized as being a lot safer. We're not allowed to do electronic prescribing for controlled substances because the DEA won't sign off on narcotics. You have to have a paper prescription because they say, well, that's safer for law enforcement. Now, lots of things go wrong with paper prescriptions. Prescription pads are stolen, addicts forge signatures, you know, people, they're not readable. But the point is also they're not secure either. It's not as though saying, oh, you know, the doctor had to sign it manually, therefore we prevent these things from going awry. So I think it's always a balancing of what's not safe, perfectly safe, but what's safer, and how do we improve those things. I think a lot of people share your concerns about what are the risks that go along with this. All I can say is a lot of people are trying to pay attention to that problem.
One particularly good visualization that I heard from Chief Information Officer was if we consider a library and we want to say that we want to have perfect security in that library, we never want to have a book stolen. That can be done. And the way to do that is you never let people take any books out. And so as soon as you let people take books out, as soon as you do any sharing at all, there is some risk that's greater than zero. But if you balance that risk against being in an emergency room and needing someone to know the 5 different medications that you're on, that's where people really feel pretty good about saying, maybe it's a good thing to have my records integrated. And I will pass it on to Diane. I'm sure you...
I was going to ask a question, so if anyone else. Have you been in provider offices, physician offices, labs, radiology centers where they are using the electronic health record now to collect information during your visit? Have you seen this sort of in action? Or called up and even said to the administrator in the provider office, I need to know this, this, and this, and they can call it right up and give you your answer instead of saying, oh, I'll send the clerk to the medical records room to bring back your record and get back to you this afternoon. So you see this happening in this state right now. You see the data being collected electronically, sort of going forward. And then, of course, the conversion process with your paper records is a whole other project.
The question about, there was a question, though, about what kinds of things you can do. And I think the answer to that is really talk to your healthcare providers. If they don't have an electronic health record, that's probably a pretty good thing to ask, good question to ask, because if it's used properly, it can really give you better care. One of the ways it can give you better care is, for example, if you're on a blood thinner and you have to do a blood test every certain amount of weeks, the electronic health record can actually send that information to the office manager and saying, you know, call Mr. Smith, they need to come in. Or if, you know, you're having kidney issues or liver issues, or even if you need to get a pap smear or a breast exam or something like that, you can set up an electronic health record to tell the physician or tell the administrator that you need to come in. And so that's, you know, a very simple way of making your health care better. Are there any other questions?
So for the sensitive information, mental health issues, substance abuse issues, there is a way to opt out of the sharing of that information, as I believe I understood it.
Yeah, so the answer is yes. And in fact, say if you've been in substance abuse treatment, they can't even acknowledge that you've been a patient without your permission. So it's not even opt out. They just can't say anything until you go back to the patient and say, other than in an emergency. They can release information for emergency treatment, but then they have to tell you later, and they have to make a record saying we released it to, the Winchester Hospital emergency room on this date for this purpose. But generally speaking, they can't release anything. And I think those kinds of facilities are going to be the last, if ever, to be fully, hooked up to electronic health information. I think generally for, say, AIDS, HIV tests, you have to get a permission for a release of test results. So there's an extra process around the release of that kind of information. For information from a therapist, they're not going to release anything, generally speaking, without permission from the patient, except in an emergency. So it's a real opt-in kind of. It's not an opt-out where they're going to do it unless you say no. They're not going to do it unless you say yes. And I think there's more emerging standards around how to handle the kind of the opt-in, the yes/no kind of questions are kind of coming into focus now. But it's not something, because these technologies haven't existed, people haven't thought a lot about these kind of situations.
I was just going to add an example of Mass General and McLean are part of the same healthcare system. They're both part of the Partners healthcare system. Partners has an electronic healthcare record system, so that if you're at one Partners hospital and then you go to another Partners hospital, they can pull up your record, with one exception, McLean. If you have an inpatient stay at McLean, even if you show up at an emergency room of Mass General Hospital, they will not know that you just came out of McLean, because that information is protected in a different way. Now, you could argue that that's not a great thing for your health care, but the balance there is for privacy, to protect the privacy of the people, unless they give their explicit consent. Is emergency a defined term?
I think it's probably a little broader than life or death, but I think to the avoidance of either death or serious injury or permanent impairment of your health would probably classify as an emergency in that case. And I think the real, I shouldn't say the real, but one of the primary things people have been focusing on especially is the sharing of medication information for what they call medication reconciliation. And any of you who've been in the hospital, right, how many times do they ask you, what other medicines are you on? It's like you walk in, they ask you get in the bed, they ask you get out of the bed, they ask you, another nurse comes in, they ask you again. And in part that's for safety, but also I think it's a small illustration of, there isn't a single authoritative source of this information that people can just look to and say, these are all the medicines that Dave is taking. And this is what happens if we prescribe another medicine that might interact with all of those things. So that's one of the key issues, I think, that they're working on as a first priority. Yes, ma'am. I'm going to repeat it for the camera. Can the police department or your insurance company get this information? That is a very typical and appropriate question. Police department, the answer is no, with very, very limited exceptions. If your hospital had to report a crime on the premises, that might result in, or something like that. Or a therapist can disclose information to avoid immediate injury to a particular person, and that's the kind of case where someone says, I'm going to go shoot my ex-girlfriend, tomorrow. The doctor can pick up the phone and call the police and say, I think we have a problem here. But generally speaking, no. There are some specific rules about blood alcohol tests in the emergency room, and I can't remember what they are off the top of my head. That might be one area, but generally speaking, no. The police can't just walk in and say, we'd like to browse through your medical record and see if there's anything interesting there. They cannot do that. What was the second question? Insurance, okay. Your insurance, they can't just call up and say, gee, we'd like this information. However, there can be a number of circumstances where it's going to be revealed sooner or later. And let me give you an example. You apply for life insurance. The company's going to say, well, that's all well and good, but we're not going to issue a policy until we've seen, your medical history and background, or until our person actually comes out and examines you, which happens sometimes. So they can't just call up your doctor and get it, but they can decline to issue you a life insurance policy until you sign a release. So that, say, applies to life insurance. In this state, health insurance is not individually underwritten, and what I mean by that is, in many, many states, if you've been sick, it's very hard to get health insurance. That's not true in this state. We have guaranteed issue of private health insurance, so no matter what your health status is, you can get health insurance. For some of these other things, if you've been in an accident, well, if you sue somebody and say, I was hurt because, Geraldine here ran into me, ran me over, sooner or later, my records are going to end up somehow involved in that lawsuit. It's because I filed the lawsuit, but it's, going to be because of a court order or subpoena going to my doctor. And there's some legal process around that to make sure only information that really relates to the lawsuit is released. But eventually, I can't sue Geraldine and say, you hurt me in a car accident. Say, of course, I'm not going to let the court look at my medical records. It's kind of like the flip side of the coin, if you will. So they can't get it automatically. They can't just dial it up in a database. But if you try to buy insurance or you do some other things, then you won't be able to complete what you want to do unless you consent to the release of your information. So it's kind of two sides of a coin, if you will.
Is that the kind of insurance you meant exclusively? The life insurance, the car?
Being where seniors and car insurance, they can always look the records up and say, well, it's her fault if the accident happened.
All right, so it's the automobile insurance, because if you're meaning also insurance like, well, take Medicare or take the commercial insurance companies here, they can get your clinical information to assist in paying a claim, validating a claim. They can do it under terms of case management to make sure the care you're being given is necessary, appropriate, approving transfers for you to different kinds of facilities. So health insurance, as we know it in this state, and Medicare, yes, additional information can be provided about the care rendered by your physicians. I didn't know if you were also contemplating that in the general term insurance. Okay. Because a lot of times people say, I don't want my health insurance company to know this. Well, they paid the bill, they know this. So, all right. You're ahead of the game on that one, okay.
Other question?
I see your hand getting raised. Yep. For concluding remarks?
Actually, what's being done to raise the bar, so to speak, nationally? I mean, Massachusetts may have these, wonderful protections, but once the information crosses state line into another state that doesn't have the same protections, I assume that, the Massachusetts rules, laws, regulations no longer apply. And, HIPAA may set a floor, but I don't know if it's, how much comfort that gives me. I do appreciate what Massachusetts does, but that, that's not going to be truly effective until it becomes nationwide.
Sure. Well, there are variations in the law from state to state, so they're not the same. And for some reason, the coastal states seem to have stricter laws than the states in the middle, big, flat part of the country. I don't know what the reason for that is, but we were all involved in a national project that made that seem to be true. I will say this, as part of the stimulus legislation, the HIPAA protections were made a lot stronger. The penalties were increased substantially. The rights of patients to control, require their information to be disclosed in electronic form to another healthcare provider were increased. There were a number of your right to get a notice if there's a breach of your information was put in federal law. So just like you might get a notice now about a credit card, soon there'll be a law that says if your health information is breached, you'll get a notice from your healthcare provider or your health insurance company telling you what happened. So while the laws are not the same across the country, I think HIPAA has been strengthened And there are, if people say, well, there's no controls or there's no protection, I don't think that's accurate. I think there's a lot of protection across the country now. One of the things, though, that people have found is people imagine, well, I'll be, medical records zipping across the United States. The number of instances where that happens or needs to happen is actually extremely rare. The one big exception or the two exceptions I would point to is one is students. One of my kids is in school in New York State, and if something happened, there might be a need to exchange information about him. The others, of course, is people who are have two homes. They're up here until the weather turns bad, and then they're down in Boca Raton or Arizona or whatever, and maybe also being a frequent flyer on the healthcare system as well. And better solutions need to be developed for the sharing and secure transmission of information, to suit folks in those situations, which I think those solutions will come because people will demand them. But the national laws have been strengthened, so, they're not the same everywhere, but there are privacy laws across the United States. And I don't know how we're doing for time.
I think we're doing fine. Last question. If not, we'll thank you. Do you have any last question?
Go for it. I'll just repeat it for the microphone. So.
What does this pretend as far as having a central repository of your medical information?
There you go.
I assume records are still fragmented then? I mean, it could be all electronic, but it's still going to be scattered among all the providers that serve me. What is this all leading to? Is this going to lead to a centralized storage of our medical records in one place?
That's a great question. The question is this leading toward one central storage place for all medical records? And, one answer is, of course, as Yogi Berra said, it's hard to make predictions, especially about the future. So this would be a prediction. That is not the trend, especially in Massachusetts. There's more, the trend is toward having what they call federated systems where people are connected to each other, and there are ways by using technology like electronic indexes to say, where are all the records about Dave? Who would have those? And then some appropriate way to transfer maybe a summary or the key information to the place where it's needed. There are just too many questions about big repositories. Who would control them? Who would protect them? Who would set up the rules? That people generally in most states don't want to bite off that many questions, although there are some places in the country, Louisville, Kentucky, for example, is trying to build one big repository for the entire community, and we'll see if they succeed or not. I think it's a lot to ask people to believe in. So probably no, although there is one big repository that has a lot of information about a lot of Americans. It's called the Medicare program, and they have a lot of data, and you don't see, generally speaking, Medicare beneficiaries marching on Washington saying, break up the Medicare program because we're worried about our privacy. Another big one that is the Veterans Administration, has records on all the veterans, and a health system that has really improved its performance as a result of computer technology. They have had some breaches of credit card and that kind of information, and they've had to respond and deal with that. So I don't know, you can make a prediction too.
My prediction is going to be the same as yours. I don't think we're ever going to have a central repository. There are too many questions about how to keep up the quality, how to keep it updated, what's the gold standard for it. Whereas if you talk about creating a standard for a summary record, that makes sense to me, and that's something that I think has a chance of actually succeeding.
I have nothing to add to the discussion. I mean, I could.
Okay, so with that being said, I want to thank you all for coming. If you could, just as part of our contract and our grant, if you could fill out the evaluation, because we really want to know what parts of this video resonated with you, what you thought needed work, what you thought we could do to improve it. That would be really helpful to us. So those evaluations, hopefully you've gotten them all. Also, I have copies of the slides if you want to take it to look up some of the resources that we talked about. Please take some munchkins home. And thank you all for coming.